Dear guests, we are delighted to welcome to the stage the moderator of our next panel, the Senior Health Correspondent for Time Magazine, Alice Park, and our distinguished panelists.
Good afternoon, everyone. It's my pleasure to be here to moderate this next session on health and human rights, with a particular focus on finding ways to take grassroots efforts and formalize them and make them more sustainable. So it's my pleasure to introduce our panelists. To my immediate right is Geetha Tharmaratnam, Chief Impact Investment Officer for the WHO Foundation. Sitting next to her is Nidhi Bouri, former Deputy Assistant Administrator for Global Health at USAID. And next to her, Sriram Shamasunder, Professor of Medicine at UCSF and co-founder and faculty director of the HEAL Initiative. And last but certainly not least, Alina Dorian, Associate Dean for Public Health Practice and Associate Professor in the Community Health Sciences Department at UCLA Fielding School of Public Health. So thank you all of you for being here today. Before we get started, I do want to address, the theme that we've been hearing about all day today, which is, as Dele so eloquently described it earlier today, the cold winds that are blowing from Washington that are having really a chilling effect, particularly on the global health landscape. So, Nidhi, I wonder if we can start with you to talk about, USAID, which, as we all know, has clearly been drastically impacted by the new administration's decisions, and there are talks about eliminating it altogether. So tell us a little bit about what you're hearing from your colleagues on the ground about how these decisions, how these cuts are impacting health programs. Everything from HIV through PEPFAR, maternal child programs, malaria programs. Give us a sense of the impact that this decision is having.
Sure, thanks, Alice. So I think, as many people probably know and have seen, USAID is on track to be fully eliminated, despite the fact that eliminating a federal agency does require concurrence from Congress. The one thing I'd say is it's not unusual when administrations change that there are different policy priorities that administrations have. So it would not be surprising for this Trump administration, much like the previous Biden administration or the first Trump administration, to have different areas that they might want to spotlight more through their foreign policy. The issue is how this administration has currently gone about looking at foreign assistance. And unlike other governments that have gone through a merger of their development and foreign affairs agencies like the UK or the Australians, this has not been done with a glide path, and it is the lack of a glide path that has been so catastrophic to programs around the world, not just in health across a range of sectors, but within health. And specifically what it has meant is an abrupt termination of funding, which has catastrophic downstream impacts on the ability of organizations to keep the lights on, to keep staff employed, to procure commodities needed to deliver health services, the ability to support partners that work with them. But also what we've had is not just the abrupt termination. It has been really quite chaotic of a turning the lights on, turning the lights off, on and off again, which is actually not that easy to do. And so the combination of systems and processes that USAID had in place to support partners around the world has been completely dismantled. Then there's what's happened to the USAID workforce, so not having people in place in different roles that execute different functions, so that if there is a apparent turning back on of programs, the people aren't necessarily in place to help make that happen. And the individuals who are feeling it the most are the people who receive services on the other side of those programs. And we have seen across every area of health pretty significant immediate impacts with terminations on the ability of children to get routine immunizations, the ability of mothers to deliver babies safely, the ability of distributing products like bed nets that we know are critical and an easy way to prevent the transmission of malaria, and so on and so forth. But we've also seen a range of programs that in theory would have been kept on because of what we would consider national security purposes, like preventing outbreaks from spreading, also get eliminated. And the challenge that I think the community broadly has now is what is a way to move forward when you have a bunch of pieces without an ability to bring them back together? And it is, in some ways, I think, while I do not want to discount how irresponsible and catastrophic this dismantling has been, it is a forcing function to think of how to have a hard reset for the global health system. Because one of the biggest issues that this process has highlighted is when there is a significant dependency on certain sources of aid and that automatically or abruptly goes away, there is not necessarily opportunities to look at how to fill gaps holistically in the interim, and that is what's needing to happen. People are triaging. It's how to keep different programs alive in some capacity while looking long term in terms of kind of what a system can look like. But as was commented on in some sessions earlier this morning, we will see, I think, significant backsliding in development gains, in health gains, and we are already starting to see that. So for example, we have already seen actually some very early data that shows because of certain aspects of PEPFAR, the flagship HIV/AIDS program for the US government that have been eliminated, with only select activities being supported, and even that with some holes in it. But we are already seeing data that is showing potentially increased transmission of HIV among certain key populations, because the current administration policies to support continuation of HIV services does not apply to all populations who are in need of HIV services. So there is a elimination or a lack of including LGBTQI populations in particular. And when you combine that in countries that criminalize those populations, where the only way of getting services was through programs that were supported through international assistance, it is essentially cutting off a lifeline for people and putting them in a position of not being able to access services for things that were in fact preventable. We've seen an announcement to eliminate funding to Gavi, which is the international organization that works with a range of governments in supporting a package of routine immunizations. It's a little too early for us to see the data, but I think they're good projections that knowing how much routine immunizations have saved the lives of children under the age of 5, if those immunizations stop and there is not a way to transition it, we would likely see an increase in child mortality and an increase of diseases of children of certain ages. So to your point, Alice, we're seeing immediate impacts, but I think also have enough to know what are anticipated impacts in the near future from these cuts. And the complicating factor, of course, is that while USAID has been a pretty significant and the largest donor for most global health programs, the agency for consistently the last few years would put about $10 billion in global health assistance across programs across the world. We're seeing other governments follow suit. And so what we're looking at is pretty catalytic shifts in the funding environment of what that means in the long run.
So I was going to ask you about whether there are alternatives, and if US aid is no longer there, do local governments step in, and are they able to? But I think you gave a good example of one example where there is nothing else, correct? And so therefore we will see some more catastrophic effects on health outcomes.
I think we will see catastrophic effects. I think the opportunity in this period of chaos is to really look at meaningful ways to come in behind governments and national health plans in advancing health outcomes. So one of the challenges in the health space for years has been this tension between disease-specific programs and cross-cutting investments in health systems. And that has not been an intentional tension. It's just that there are a lot of programs that have evolved because of their focus on HIV, their focus on tuberculosis, their focus on malaria. And particularly after 2020 and the period of COVID, we saw health systems around the world, including here in the US, get turned upside down, where a range of health needs were spotlighted, the lack of ability to get services for chronic disease management, for routine health care, specialty services, all kind of heightened. And so what we have seen consistently in the last few years is a real ask from governments around the world to invest more in their systems and to specifically invest in primary health care or an expanded package of routine health services. And because we are in a period now of having to look at the vacuum of USAID funding, it is an opportunity to look at how investments that come in, which will not be likely enough for what is needed, but could be reimagined to be more in line with helping governments accelerate outcomes and be more of a way of supporting countries in that process, while also having some funds that specifically, of course, support routine or rather emergency needs. The caveat is that will only work for governments that actually want to deliver health services to all people. And so there will, when you look at some contexts, it's possible, like for example, Kenya, I think is a great example, that has consistently moved towards supporting outcomes for disease-specific programs like HIV, but has consistently looked at expanding primary healthcare services. I think there could be opportunities, not just with what U.S. government foreign assistance looks like, but other assistance coming in that could help kind of position governments in their ownership and leadership in their vision for health.
Okay. Geetha, I wanted to also ask you, I know that you represent the WHO Foundation, which is slightly different from the WHO, but all part of the same family, which is also feeling these cold winds that are blowing through, and we've recently heard the Director General say that there will be a necessary 25% reduction in staff costs, and that will translate into probably fewer services and some programs affected. So tell me about what role WHO Foundation can play in that, and whether you're also being asked to sort of step in and fill in some of that gap with the U.S. no longer part of the membership of WHO, having been one of the largest contributors to the organization.
I think there's two parts of this. The first of which is it's not just what is happening with the US, it is what is happening globally. There are knock-on implications which is resulting in less funding being available across the global development space, in health, in financial inclusion, in a series of initiatives which have required multi-year focus. And so what we are trying to do as the foundation is catalyze funding from the private sector to in greater numbers. And I want to pick up on something Nidhi spoke about, which is where's the opportunity here? The despair is plentiful, and it is painful. And it is painful, especially for those of us and those of you who have done a tremendous amount of work to try and make a difference over a very long period of time. And as we think about where the opportunity is, the first is around agency and what it means for our countries around the world to choose how they want to take forward the development agenda going forward. These cold winds have laid bare some hard truths. And so as you think about rebuilding with a different focus, the first question is, what is urgent and immediate now? And what is investment that is needed over a longer period in time? If you look at healthcare, as an example, across all our continents, our people are going to the private sector for their healthcare. Low-income individuals as well. They're paying out of pocket. No insurance, no other solutions. We're seeing those same dynamics on the education side. It has also given rise to types of businesses who are providing these services, who are providing products at quality points which are not sufficient. And so as we think about what it takes to build resilience into our systems going forward, there is the promise of what technology is going to be bringing us. But this is a conversation we had on a different panel yesterday, Alice, in terms of being careful to know that technology is not a solution in and of itself. We still need human resources, again, in a sector which is stretched even more as our disease burdens are changing, as our disease burdens are increasing. So for us at the WHO Foundation, what we're specifically looking to do is actually ramp up our activities in terms of linking the kind of engagement of private funders, whether it's corporates, whether it's philanthropists, whether it's foundations, whether it's investors, to a health outcome agenda, which is linked to the mission of the WHO, which is health equity for all.
One of the themes I think that we're hearing here is that we really need to focus on locally based and self-sustaining models and programs, especially for health. And for decades, I think the model of global health aid has been, parachuting aid in, resources are there, personnel are there, and then they leave, right? And so the outcomes sort of improve for a little bit, and then they start declining again. Shri, I wonder if you can talk about HEAL and how you are really taking this model and making it more sustainable, making sure that it does last, making sure that, there are lessons there that are passed on, and that, they're not just temporary.
Yeah, thank you. First of all, thank you for having us, and just hearing this this day. There's a concept in Buddhism called noble friendship, and you may not know all the people in the room, but all of us share a lot of values. So it's been a powerful day. I would say HEAL, it stands for Health Equity Action Leadership. It's a health workforce program that works in Diné communities, Navajo Nation, indigenous communities in the US, as well as multiple countries around the world, Malawi, Liberia, Haiti, and actually formed after the Haiti earthquake, as many of us that are health workers were there trying to be of assistance. And one of the things that was obvious was, while there was a lot of goodwill amongst outside folks, there wasn't a lot of building of the local workforce, even several weeks after the earthquake. And so we designed HEAL to really, if you're gonna be in solidarity as an outsider coming into a community, how do you do it in a deep way, and supporting the local workforce. And I think one of the stories that comes to mind during COVID, Navajo Nation, that is in the Southwest US, they already have a 30% vacancy rate of their health workforce. And during COVID in March of 2020, pre-vaccine, they had the largest surge in the world. And they were saying, our respiratory care units are gonna shut down. How can you come and support? And we had been there, had been working with Navajo Nation, supporting, training, and transforming the workforce for the last 5 years. So a number of us came to support, and I remember taking care of a patient, an elder. We were all in our PPE, and I was speaking to him through a mask, and there was a Navajo nurse assistant that whispered into his ear in his language, in Navajo, and I could see, his face just completely relax. And there was this sense that no matter how committed I am as an outsider, we really need to support the local workforce. We always say that we're running a sprint, but the local workforce is running the marathon. And so they are often overwhelmed, under-supported. There's too few of them. And to have pathways for them to grow, to be connected, to be sustained in this work, that's the work of HEAL. And I think for the lessons as we think about USAID and so many global funding streams, there's this component of self-determination that I think you're hearing more and more, and the health workers in those districts, in these rural areas, are taking upon themselves to figure out, we need to control our own destiny and our own health systems. And I think that narrative needs to be lifted up more.
What has been your experience in terms of what they need most? What are you hearing from them? Is it support from local leadership, local governments to buy in, provide resources, make it a priority, in local government? What are they needing the most to be able to sustain their own sort of in-country network and health workforce?
I mean, of course, funding is crucial, which we've been talking about, but I think for a lot of health workers, if you think about burnout, if you think about brain drain, if you think about retention in these rural areas, for a lot of them, it is having this, ability to have mastery, autonomy, and purpose, right? So being upskilled and being skillful in the profession that you came into, but also having pathways to connect to others, because I think all of us know that you can't do hard things alone. And so I think one of the things contributing to burnout, obviously folks need a living salary, and they need to be able to sustain their families. And I think for a lot of folks, the what Paul Farmer has called stupid deaths. You know, when you're working in these contexts, you see needless suffering, and you see a level of patients dying from things that we know how to treat, that we have access to those medicines in different parts of the world, but they're still dying. And so I think this concept of moral injury, where health workers, frontline health providers are seeing this needless suffering, and they're wanting to change the system. And you have to do that in community, in connection, and not be isolated. And so I think one of the things people are asking for, of course, is a living wage. And for community health workers, that's crucial, and that doesn't happen in most parts of the world. And pathways to grow in their profession, and then obviously holding it together as a community for these concepts of moral injury, seeing hard things, and trying to move forward together.
Alina, I wonder if you can talk about how academic institutes can really support that mission and support ways to really reinforce and prioritize community-based resources, you know, at country levels.
Absolutely. Again, thank you for having me here. I think this morning Eric said something from Francis of Assisi, and I love the quote, which is, "Preach the gospel at all times, and when necessary, use words." And I think that's the sort of everything we've been hearing today and modeling. And I think before I get to sort of the academic institution piece, I think it's important, especially for academic institutions, to actually define what community-centered work actually means, because it should be community-led work, right? Which is what we've been talking about. When we talk about where the investment should be, the investment, the power, the leadership, the governance, the agenda setting should be at the local level, right? I always teach my students that we are just tools. We are a subject matter expert who knows this much, but the community is really the expert, right? And so thinking about what that means and translating that to an academic setting is a little tricky, in the sense that I read somewhere, I think before coming here, that the forum had 3 core values: courage, commitment, and impact. And I think doing community-led work takes courage. And it takes courage because it takes humility. And the difficulty in that centering is that so many of us educated, competent, well-egoed systems, and I put a happy face emoji after I say that, it's harder to sort of really, truly give the control and the power and the agenda setting. And we really sort of walk alongside, if not behind, these communities through technical assistance. Surprisingly, academic institutions are not that good in community-centered work, because many of us are research institutions. So we're driven by traditional research. And even here, you know, even funding models we just talked about, we need multi-year funding to have true engagement, because community-led work is all about relationships, right? It's all about trust. Those are things that move at the speed of building a relationship, building trust, not outcomes and deliverables. So in an academic institution, there's sort of 2 things that we also have to think about. We could be amazing partners because of the skill, the training, those things that we can bring, but we also need to think about our own systems here valuing community-based work. Tenure and promotion here at the university does not value community-based work. It really looks at publications and quantity and sort of what we're doing, and the work that we do does not sort of work on that timeline, those rubrics, those metrics. So there needs to even be a redesign at these partner levels, right? And sort of thinking about what this work actually means. Because, you know, again, when I talk about this in our institution, and I will say UCLA is actually doing a really good job in trying to redefine sort of tenure, promotion, and a lot of people, a lot of faculty have a hard time embracing what does that mean, community-engaged scholarship, actually. But I always say it's not just what we do, but really importantly, how we do it. And I think it's that how that brings to life the truth of community-engaged work. One of my students once talked to me about the dash. They said, like, you're born on a certain day, you die on a certain day, and the dash is everything you do in the middle, right? Which is sort of where the magic of community-led work happens. It's of the process and sort of thinking about that together. But again, academic institutions are also, not to fall on deaf ears, we are also losing our funding. We are also facing very We're operating in the gray. We don't know what will happen next week. I don't know where my research portfolios will be. I don't know what will happen in 15 minutes. So I think there's sort of that understanding, and coming back to what was talked about, which is how do we reset on principles and really think about how to reinvest. This is our moment. It's almost like our own disaster, where you start really resetting and thinking about how do we move forward with truth and authenticity and process.
Geetha, on the issue of funding and financing, obviously, which is, the foundation of a lot of this humanitarian health work, can you tell us a little bit about some novel mechanisms, frameworks that either you at the foundation or that you've seen in countries that could begin to address, all the kind of cold winds that we're seeing now blowing through this area?
Sure. I think there's 4 things that you would want to look at from a financing perspective. One, and looking at this from an instrument. So one is non-return seeking solutions, whether you call them grants, whether you call them technical assistance facilities, whatever you want to call it. Then you look at guarantee structures. You look at equity type structures, you look at debt type structures. And within all of this, there are ways to align this funding over a longer period in time with outcomes. And it can be a combination of outcomes, whether it is a certain financial return, whether it is a self-sustaining type of return, whether it is going to be forgiven at a certain point and linked to outcomes which are related to perhaps health. So there are mechanisms that you can craft. Blended finance has been an area which has been considered to be quite promising, especially in terms of addressing some of the challenges around healthcare financing. But as of 2023, Convergence estimated that only about 3% of blended finance transactions in the world are health-related. But when you look at just investing in healthcare, there's less than 10% of the capital that goes into investments that's going into healthcare. And so whether it's on the private sector side, which is purely seeking profit, or whether it is on the development side, there's a long way to actually go. But there's solutions that can be put in place. We're going to have to suspend some of our usual thinking, especially around what we consider to be risk. And what when I'm talking about risk, it can be anything from the risk associated with investing in or putting capital into some of our countries. It is the risk associated with the volatility of the currency in those countries. It is the risk associated with the people who are being served by the businesses or by the solutions there as well, and their ability to pay or repay over a period of time. So there are some solutions that are out there that have been tested. There's some which have the opportunity to go further, but it's going to take a different mindset, including leveraging really limited financing. And this is why guarantees, for example, can play a powerful role in terms of taking limited financing and having a guarantor say, if this fails, we'll step in. But subject to it failing, put the money on the table and move forward with the solution.
Why is healthcare and investing in healthcare such an unattractive proposition? Is it the long-term returns, that it takes so long to see a return? Why is it so? What are you hearing about why it's such an unattractive investment?
Oh, it pains me to hear that it is being thought of as unattractive, as opposed to that there are other sectors that seem easier to get the kind of returns that may be faster to get, whether that's financial services or seemingly easier to scale in a faster time period. And that could be, something related to FMCG or things that, you are buying and selling more easily. So I think for most investors, you look at what the alternatives are out there and you make a decision as to where you think you would want to put your money. And often that is linked to a time frame. Now, if we had more readily available data, I think you would see that healthcare investments can be actually very stable investments. You may need more time to recover your funding, your investment capital, but it can be quite stable as well. So there is a level of communication that needs to come out in terms of being able to tell that story as well.
Right, and there's also probably some pretty strong data that can go behind that investment, right, to show that there is a pretty large percentage that chance that you will see a good result. You know, you will see a reduction in maternal mortality or child mortality, but that often isn't conveyed because it's that time period to get to that point that you know, often some people feel, I think, is too long, too far in the
Absolutely.
horizon.
Absolutely. And it's also sometimes considered someone else's job.
Right.
So where it is considered the aid industry's job to be providing this financing, you can have private funders sitting there going, well, that's not for me. And we're now at a point where it is all our jobs. And as we think about fundamentally rewiring how health is going to be provided in the future, whilst taking into account the severe urgency of a backlog that has been built up of services that are needed now, but also the heavy levels of infrastructure investment that is needed to lay the foundation for the way that healthcare can be effective and hopefully more cost efficient, you know, value-based care with tech-enabled solutions going forward. There's infrastructure investment that is needed now and over the next 10 to 15 years. So it's changing the shape and the dynamics in terms of how you're even thinking about what is considered health infrastructure or healthcare investing versus what you would have thought of it as being even 10 years ago.
Nidhi, you talked about some of the kind of negative extremes of the impact of, you know, this, of the U.S. Reduction in support. Are there examples of really locally implemented plans on the positive side where we really see locally based, community-based programs that have really kind of taken the ball and run with it and are thriving at this point?
Yeah, no, there definitely are. So actually, in South Sudan, the Ministry of South Sudan in 2017 launched something called the Boma Health Initiative, which was actually inspired by some efforts that started with grassroots health efforts focused on malaria and tuberculosis. And through the programs that this initiative was designed on, it really centered on equipping community health workers with a standardized package of health services that they could offer communities, and then they scaled it at a national level. So we typically think of grassroots and locally led health as being reactive or defensive when something is not happening, but it's actually a great example of a government responding to a model that came out of a locally led initiative and saying, this actually is exactly what we need and this works. You know, there might still be, of course, a need for external support for supply chain, for upskilling in specific technical areas, but I think it's a great example of when you invest in looking at supporting locally led solutions, because it is those people on the front line, as Sri talked about, the health workers working with communities that know what are the needs of their community and what is needed perhaps to respond to it, but also what might not be in hand to help respond to it, that can inform the way some programs are designed. There also have been some really interesting creative programs. There's one, I believe it's in Zambia, working with soccer teams that have a youth component, of course, and using the teams as a way to create champions for sexual and reproductive health care, to push out information on HIV transmission, on family planning, on decision-making. In Afghanistan, there's a program that actually has now paying lasting dividends now that cut all services that were previously supported by USAID in Afghanistan have been cut off now. A mobile platform that was modeled off a program in Tanzania and Kenya called Mobile for Reproductive Health, which pushed out proactively information through calls and texts to women and their husbands around family planning and reproductive health. So as was mentioned in one of the panels before, in a cultural context now particularly, that requires women to have a male decision maker with her to seek care, and a very small number of female healthcare providers left in the country, proportioned to the number of women, a way to put information in the hands of people directly so that they are informed in a way that perhaps they wouldn't be otherwise. So I think all of these are great examples, I think, of pushing information out, but also shaping and refining services to actually meet the needs of communities. And sometimes that means building out programs to be a bit more holistic and looking for opportunities that might focus on one area of health, but to add in other health services if it's found that a community is in need of different things.
And Shri, I wonder if you can also sort of pick up on that and tell us about some of the examples that you've seen where you're hearing from local healthcare workers, community healthcare workers, and what their needs are and how they might differ from one community to the next.
Yeah, I think one of the evolutions of HEAL, which we started 10 years ago, and it's really a cohort model where there's all these frontline health workers, some from the US, some indigenous, some from international, global south, and they're all coming and learning together. And one of the things that's been interesting as a evolution is that many of the health workers, the alumni that have gone through HEAL, have said that, no matter how powerful this is for me, there's more marginalized health workers that don't speak English, that don't have a passport, that you need the hyper-local adjustment of the model to those contexts. And so now we're running cohorts in Mexico in Spanish by alumni, in Malawi by 10 years of Malawian Ministry of Health workforce that have adapted the curriculum to that context, and then same in Navajo Nation with indigenous health workers. So they're adapting, they're integrating a lot of the ideas of decolonizing global health, indigenous wisdom into their curriculum and their mentorship. So there's this notion of for us, by us, and nothing for us without us, right? Where a lot of the workforce has taken, like my colleague was saying, a academic program, HEAL, that started in the halls of San Francisco, and it's really become hyper-localized to the context where the health workers have benefited from, this academic institution, and that we've leveraged all the knowledge of an incredible medical center, but it really needs to speak to the context in which they live and work every day.
Alina, one of the things that I think often is ignored when we focus on humanitarian health, particularly because it's so emergency-based, right, that is the mental health aspect for both healthcare workers, the workforce, as well as for those, undergoing the emergency, whether it's a flood or a hurricane or, infectious disease outbreak. How do we take principles and understandings and data and things that we understand are important and that we need to be part of a holistic program and apply those to community-based programs that are still in a way that's very, locally sensitive and relevant to community-based populations?
Yeah, thank you for that question. So I wanted to also, just going off of that, sort of piggyback on this concept of public health, right, in general, versus just clinical health or health outcomes and health systems. And I think this is really important when we talk about health outcomes. A lot of the programming we do will not shift maternal mortality in the 1 year that we did that program, or the 2 years, right? But it will build capacity. It will have other intermediate outcomes that are very important that we don't always define sort of in the way that we should in showing kind of that link around well-being, right? Sort of health and well-being as a larger metric. And thinking about some of these programs, and I'll go to the mental health, which is this idea that there's a lot of upstream determinants, right? With determinants of health as we're working with all these things. And how do we think about linkage and resilience in doing this work? I will give you an example of the mental health. So at the end of 2023, in response to the forced displacement of the entire population of Artsakh, Nagorno-Karabakh, into the Republic of Armenia following full-scale conflict, UCLA FSPH, which is Fielding School of Public Health, the American University of Armenia, we were already on the ground doing work in Artsakh and then came over, and we were able to work with the refugee population in creating a community well-being program where they truly co-develop, co-implement response and recovery. And the overwhelming majority of the staff and leadership is from Artsakh. And one of the most notable components sort of what we have been able to do is they created a new cadre called community well-being workers, which is really a riff on community health workers, but sort of looks at it from a larger perspective. And it's something that Armenia doesn't have right now. So of course they're community champions, cultural mediators, everything you would expect them to be, human anchors, heroes, friends, and doing all the work that they're doing to rebuild social networks and local capacity. But the concept is that today, we're piloting it again with the refugees, but ultimately this can be replicated throughout Armenia for all communities, represented by the communities, the CWW model. And something Sri said, which again, always, they also, one of their big things was around community self-determination. And those words really echo in this refugee population, and they really echo because of the history of Nagorno-Karabakh and this concept of self-determination. So off of that, when we think about mental health is a really difficult, I don't want to say component to response and recovery, but it is. And the reason it is because it's integral, like full stop, it's integral to recovery, safety, and dignity. But unfortunately, it becomes sort of a secondary concern, an afterthought, because it's difficult, because of resources, because of the cultural context, because of many, many things, right? But the reality is, trauma is not temporary, right? It lingers in bodies, in families, in communities and systems. Actually, a lot of our systems create trauma or were built on trauma, right? And so thinking about all of that as well, but healing needs to be central. And mental health, when we define sort of programming, I believe we need to really look at it as a universe of care, right? Like sort of a continuum of care. It's not just about specialized clinical services, but it's about psychosocial support, right? Sort of that building that context around coping mechanisms, community well-being again, but obviously really steeped and honoring cultural, spiritual, collective dimensions of health, which means that it needs to be the local definition of those things, right? So locally defined healing. But to be honest, these should be done before a disaster, right? This is where all of these issues come into play. It's so much more difficult finding all of these local actors to bring them together and sort of do all of these things. But again, mental health programming is really restorative. It's about the connections, the meaning, and safety. And we need to really think about how to locally define that and pull sort of all of these things together so that it is rebuilding of social fabric, not just provision of services. And I will tell you right now in Armenia, I will say most of the groups doing work are trying to focus on mental health because of the stigma, the taboo, the sort of the understanding of those words, because they think of it as clinical health only, sort of specialized clinical health. And this concept that in many ways it's easier to work with pediatric populations, like families are okay, versus really thinking about sort of adult populations when we think about this kind of programming. But I think one other really important piece for all of us in the work that we do, especially following disasters, is this concept that every single touch point that we have is through a trauma-informed lens, through trauma-informed programming. So everything we do should sort of embody kind of that concept. That is not to say that we don't need specialized care, but it's also the sort of the smallest resource in most of these countries, even in our own, right, when we think about sort of mental health services and what we need. But again, really thinking about how we could build local capacity prior to all of this, well, with everything, but especially around this concept of at least defining what this means for the communities.
Sri, I'd love to get your perspective on what Alina was saying, which I think is so important about rebuilding the social fabric versus, focusing on services, I think, which is what so much of aid often does. How are you seeing mental health being prioritized in the areas where you work?
That's a big question. I would say that, coming out, one of the vantage points that we had, all across the places that we worked was we saw every surge in COVID hit every community, whether it was Mexico, Navajo Nation, India, and I think the devastating effects of mental health that preceded that, and then the trauma of COVID. And so a lot of our health workers have said, both focusing on their generational trauma that they've existed in and COVID exacerbated, and integrating into primary care, because a lot of these places you cannot have, it's very difficult to have psychiatrists, psychologists, but this idea that we talked about is vertical programs that have existed. We teach a public health class and we celebrate the eradication of smallpox and HIV treatment, but oftentimes those systems didn't strengthen primary care. And we know the best health systems have strong primary care, whether it's Costa Rica or Cuba or Thailand. A lot of that has very strong primary care. And if you build, mental health is long-term management, right? And so you need strong primary care, and then you need to integrate mental health services and the lived experience of our patients and the trauma that they often have endured just by the structural violence and the violence of their lives, and bringing that into how you care for them as you would for diabetes or cardiovascular care.
Nidhi, for the programs that USAID supports and provides, how do you work in areas where there is little political will or even political resistance to either providing the programs or the services? What kind of impact can USAID, and now if it's not there, how concerned are you about any of those gains being lost?
I think one of the strengths of the model that USAID had in supporting local organizations, which was an evolution over time. I mean, the agency made a very dedicated effort to shift its funding model to be more centered across all sectors in supporting local organizations. And one of the benefits of that is, as you talk about, in countries where governments may have an intention to marginalize certain parts of the population or criminalize certain parts of the population, precluding their ability to get health services, or where there is just not political will or there's just overall weak governance and kind of weak systems, the ability to support organizations that are there, knowing what their communities need and equipped to be able to respond to it, is really critical. I mean, and Shree's talked a lot about community health workers. 70% of people in the world get health services outside of static facilities. That is a higher percentage in contexts where there is some aspect of conflict or shock kind of to the system. And so when we look at humanitarian contexts, whether it's a natural disaster or protracted crisis, we know even more so the ability to equip, resource, sustain those capacities that are outside of health facilities is really the only way most people are going to get health services. And it's also a real key to addressing and minimizing inequities in health, because especially if you add on top of the layer of potentially having weak governance or lack of political will, but you have cultural dynamics that might, for example, impact a certain gender, religious group, racial group from accessing services. It's again the ability of taking services out to where people are and providing a safe and holistic way of people being able to then receive services. Though there is one thing that I also just want to note, which deviates a bit from your question, Alice, but I think particularly in these contexts is really important. One of the biggest threats to health equity, particularly in fragile contexts, is the continued rise of misinformation. And there are a lot of countries in the world where some of it originates from governance directly, or other groups in society that put out information that is unfortunately incorrect. And when people believe that information, can really inform their trust in public institutions, their trust in health services, in health products. And we see that everywhere. I mean, there's not one continent that isn't wrestling with that. But it is important because when we talk about reaching communities in these contexts, delivering health services is not just about public health or clinicians. It's about free and independent media. It's about having information that can be trusted, available, that's accessible to people. And it is all part of a bigger puzzle that is centered in supporting health outcomes, but then also the well-being that Alina was talking about.
Geetha, with the foundation able to draw upon, private and philanthropic resources, are there things in areas that the foundation can accomplish that the WHO can't, or traditionally wouldn't?
So I would say really it's engagement with the private sector on our side and making sure that there is a complementarity to programming and funding from the private sector to the private sector alongside what is happening from a public health perspective, to the point that you raised there, Alina, as well. Because we have seen that there has been a challenge to most governments around the world to meet their own health financing needs. AID has stepped in some cases, ODI has stepped in some cases, but increasingly you're starting to see models where countries are outsourcing things like primary health care, things like mental health provision, in order to try and get movement on that front.
How would that work? More digitally based, or when you say outsourcing, what does that mean?
So sometimes it is literally outsourcing primary healthcare clinics to a private provider to run them on behalf of government. So it can be as simple as that. We've seen models like that in India. We've seen models like that in West Africa as well. We also have faith-based models where you have got healthcare facilities that are being run and have been run for a very long time by faith-based organizations who themselves are trying to find alternative mechanisms to either scale or to integrate to this point of becoming more holistic. Otherwise, what you have is a siloing effect. And when that happens, you are leaving it's incumbent on individuals to carry their needs and their treatment alongside by themselves to the next part of that value chain, whether it is getting diagnosed with something, from there figuring out where do you go to next in order to get some treatment. From there on, where does ongoing monitoring of that particular issue happen? And the burden of self-care and that is extremely high, and the drop-off is also quite high in terms of patients or of individuals. I won't call them patients, individuals being able to manage especially non-communicable diseases over a longer period in time. And so here for me, the opportunity again comes back to, if we're looking at our systems quite holistically, and what we want is integrated care of individuals moving to healthier lifestyles, and where technology is something which is going to enable people to monitor their own health over a longer period in time, what that requires is that collaboration between the public sector and the private sector, but equally you need the collaboration behind the scenes on how the financing of that is also happening.
On the question of finance, Sri, what financing model have you found works for capacity building, healthcare workforce capacity building for HEAL?
I think our hope, we're working in rural parts of California. We're working in the public sector in Malawi. We're working in tribal communities. And so the goal is always to work with the public sector, because that's, no matter how excellently your NGO is run, that's the pathway to impact and scale. And I would say that convincing and having metrics that health workforce is oftentimes, it's hard to show in a short time scale the impact. And so in a very developed, in California, for example, there's a very clear understanding that the demographics are very, very diverse, but our health workforce hasn't kept up with that. And so we need health providers from rural California, from more Latino providers. And so the more established foundations, the public sector is willing to fund that without necessarily the 5-year data on that. But I think in other parts of the world, making the case, we're trying to make the case to philanthropy to bridge to public sector funding. And so I think philanthropy, is challenging because there's so many urgent needs, especially with the gutting of USAID, that it makes sense that you would try to gap fill around TB or HIV, and health workforce would drop to a second or third tier. And so I think, but in this moment, if we think about another way, another imagination after USAID, these are the things that we have to invest in, and the time horizon has to be, it can't be quarterly, it has to be the 10-year horizon. or longer.
Okay. Alina, looks like you want to have.
No, I was just going to say, I think, again, from my perspective, and just sort of going off of what Nidhi said, Nidhi was, again, referring, I think, to that bigger definition of health, right? Like, if you don't have housing, you can't be healthy. If you don't have employment, and this concept of the CWW is very much around that, linking them to all of those things. But coming back to, I think the model that's worked best for me, in general, has been one that's allowed flexibility and adaptive change as the programming is happening. So really, which is, I mean, that's a gift to be able to have that kind of a model where truly through community-based participatory like research approaches, we define the indicators together of what we want as outcome. And as we're implementing, if it doesn't work, we don't have, you know, the ego or what, at that moment we change. So that change and adaptive doesn't mean the program was designed incorrectly. It means we're trying to find fidelity in how this program should move forward. So I think having funding models that allow that adaptive change, not that what you put in is what's sort of supposed to come out at the end, and that I think is very important because it is real, it is holistic, it's what's happening locally, and I think constantly defining and redefining that allowing that through funding is really important, which is hard, right? Because the funder usually wants X at the end of it. But I think that this is the point to really step back and say, if we want to do these things, we need to allow that flexibility, still being obviously transparent and having accountability for what we're doing, but it's the process that matters, really, right? Because that's what's going to be building all of these things. So I think thinking about that when we talk about this next iteration of how we get funding and what it looks like would be really, really helpful.
And in line with that, I think in our last few minutes, I just want to go down the line and ask, you know, in a world where we're increasingly seeing competing pressures, you know, from climate change, decreased donor engagement, geopolitical conflicts, how do we really make sure that health equity and health programs are prioritized? What is one, from each of you, I'd like to hear, what is one single structural thing that you would like to see happen that you think will bring us along that road, toward that road of seeing more health equity around the world? Geetha, let's start with you.
You know, I'd start with changing power dynamics in who is being funded, how they're being funded, and please, changing the duration of the funding so that we have a chance to actually build sustainable systems.
Okay.
Yeah.
Nita.
I will also say change financing models. I mean, we need to strive for investing in health systems for the shocks that are yet to come, not necessarily just what they're dealing with now. And so when we look at investing to have resilience, I have mixed feelings about that word, from a certain threat, climate change, conflict, pandemics, we have to think a bit more holistically, I think, at a 30,000-foot level, is investments in integrated service delivery, seeing health workers as global public goods, and investing in a capacity that is looking multi-year, flexible, and with the adaptability to meet those needs.
Sri?
I'll probably have a variation, pretty similar ideas, is that, you know, I think some of the things you've reported on, Alice, it's never been a more amazing time to be a clinician, and in medicine, there's incredible technologies, whether it's CRISPR or CAR-T, or we talked about AI, and most of the places where we work, those things are so inaccessible to folks. And so really thinking about intellectual property reform, technology transfer. We saw in the pandemic, you know, we in the US and Canada, folks had 10 times the amounts of vaccines that were in a lot of communities around the world. And so how are we gonna shift our IP models, our ability to share new innovations, technology, and have the fruits of science really disseminate to the pockets of the world to make all of us safer?
Do you think COVID sort of pushed us along that road a little bit further, or no?
I would say that, you know, the HIV movement pushed us far along that road with PEPFAR, and I naively thought COVID, you know, because it's a global pandemic, that we wouldn't have this level of, you know, thinking about protectionism of your nation state by nation state, and I think you saw that, and you didn't see as much, COVAX, which the WHO wasn't as supported as I think it should have been. And so, I think as we think about the next pandemic, which, many people say it's not if but when, how are we going to shift those private sector ability to share? And a lot of this science is done on the backs of poor communities, right? So I think a lot of poorer communities are saying that if you want us to share the data, we have to share in the benefits of the science.
So we really didn't learn and apply those lessons from HIV as well as we could have to COVID.
Well, hopefully there's still time to
Yes.
shift.
Okay, Alina.
I have 2 seconds. So I think just going off of what Geetha, so maybe we're bookending, I really believe it's this structural change in community governance. I think community governance needs to be the core of health systems, actually all systems, right? And so thinking about that as a principle, truly shifting power, resources, decision-making into the hands of local actors, because that's where trust, context, adaptive capacity all comes from. And I also think that, we all need to cede some management, some control, and some power in all of that so that we walk alongside our communities, if not even a few steps behind our communities, really thinking about what that looks like. And so to me, community governance is not only moral, it's a strategic movement right now.
Okay, well, I want to thank all of you for providing your insights. It's such an important topic now and in such an important time to be talking about this with all the pressures that we're seeing. So hopefully we will see some of these solutions and promises that we were talking about here come into effect in the next few years. Thank you very much.
Thank you.